So, a very short lecture on oncology. So, these are the tumor markers, okay? Very simple, but you need to know them, memorize them for the exam. CA125. I mentioned to you guys yesterday about this, that ovarian cancer is very subtle, but it's very dangerous, okay? And unfortunately, there's not something that we can do like a really screening for, like cervical cancer, we do screening. So, in the primary care, when you suspect a patient with ovarian cancer, you need to know the signs and symptoms, okay? Always, this is going to be always there. You know, the pelvic mass, causing frequency of the urination, feeling a pressure there. So these are the local symptoms. It's going to be there. It's going to be there as a result of the enlarged tumor, okay? When you suspect that, you do CA125. If the level is 35 or more, then you do request which ultrasound? Transvaginal ultrasound, okay? And then, if that shows a suspicion of ovarian cancer, then you refer them to urgent referral for oncology or for gynae, okay? We have a gynae oncology, people who are specialists in that field. It's an urgent referral because you're suspecting a cancer now, okay? So this is the only one that, you know, other cancers, straight away referral, right? This one, because there's other things that can cause it, okay? Nice guideline says do that one first, then the ultrasound. If the ultrasound shows suspicion, then you refer, okay? If the ultrasound is normal, then you think of other causes that can be causing this, okay? 19, CA119, pancreatic cancer, very important, okay? That we will do that a bit more in surgery, pancreatic cancer. Breast cancer, okay? PCA, prostate-specific antigen for prostate cancer. AFP, you need to know. CA, you need to know. So these first three are very important. Last two here, not too important, for exam. Now, the most common cause in the UK. So, from cancer research, the current update, they say that most common cause of cancer in the UK now is, anyone know?
No, it's not.
Is it lung? So, this is breast, lung, colorectal, prostate. Now that has changed. This has been updated now. So, the first three is going to be, number one, I believe, is going to be breast. Then the actual numbering, I actually forgot. So in the break, I'll go over it. But the first three is going to be breast, lung, prostate. These three. Okay. In terms of the order, what comes first? I will check up once more. Okay. This is the Cancer Research UK. So the one you have here is not up to date. Okay. In terms of the orders, the first three you need to know. The first three, 1, 2, 3, you need to know the order. In the break time, I will check that for you. Chemotherapy side effects. Common thing, that's fine, you can read about this. Cyclophosphamide. You need to know the adverse effect of cyclophosphamide. So hemorrhagic cystitis, very important. Bleomycin, lung fibrosis. Highlight this, lung fibrosis. Cisplatin, you need to know the side effects. Ototoxicity. Peripheral neuropathy, these two are very important. Cisplatin, two things. Damages the ear and peripheral neuropathy. In the exam, peripheral neuropathy should make you always think of complication of diabetes. Peripheral neuropathy, nephropathy, retinopathy. Three things. We'll do that more in endocrine. Spinal cord compression. This will be covered more detail in neurology today. But in here, I want to mention that you see spinal cord compression is very important, and they do ask in the question in the exam, and it's an easy question. You should not miss the answer for this. So spinal cord compression, this is a In here I'm talking about there's a lot of causes of spinal cord compression. It could be a trauma, okay? It could be a Brown's quad, okay? It could be someone stabbing you, okay? It could be tumor. So in here we do oncology, so it's neoplastic spinal cord compression, meaning a tumor is compressing it, and that happens in cancer. Metastasis from the cancer. So with regards to the signs and symptoms, you need to know. Please put down in here, extra writing, just put down here. These patients, you suspect these symptoms if they have gait disturbance. What is gait? Walking. Gait disturbance, like become, and in their hands can become clumsy and weak. Bladder and bowel dysfunction. Bladder and bowel dysfunction.
Gait disturbance, clumsy.
Yeah. Loss of sexual function as well. Now, when he compresses the back spinal cord, obviously the lower limbs will be affected, right? So you're going to have weaknesses, sensory loss. Weaknesses, sensory loss. I don't need it. Okay? So we'll do this bit more in neurology about this. Now, in the exam, to differentiate, to say someone has a spinal cord compression is very easy. Also, quad equina syndrome, we'll do that in neurology. So it's very important that you know the red flags of spinal cord compression. We'll do it in neurology. Quick mentioning about the management. High dose oral dexamethasone. High dose oral dexamethasone. With regards any patient you suspect spinal cord compression, the answer will always be MRI spine, not CT, not X-ray, MRI spine. Okay? You can. Okay. The first thing you'll do MRI spine, spinal cord decompression. There's going to be urgent referral. Okay. So in here, for patients who are oncology patient, MRI spine, urgent referral. In the meantime, while you are waiting for a proper management, like surgery, radiotherapy, depending on the patient's condition. Some of them are so weak, they might not be able to handle surgery. Okay, others because of the meds, maybe okay, you can do radiotherapy. Others can't do anything about it. So until you have an appropriate management for this patient, what do? High dose oral dexamethasone, not IV, not prednisolone, oral high dose. Okay. Second thing, brain meds. Okay, brain meds you give them again high dose dexamethasone, not IV mannitol. Okay, IV mannitol causes problems. Okay, is high dose oral dexamethasone. This dexamethasone, it causes insomnia. Yeah, so therefore don't give it at night. Give it early in the morning.
What is the GCS less than 8?
GCS less than 8. No, this is complicated. I don't want to ask you this. GCS less than 8. Intubate the patient. Yeah. No, this question will not be there. Low GCS and what to give them. That will be ABC GCS. Less than 8, intubate the patient. Yeah. In here, this is important again. Superior vena cava obstruction. So you see, this patient here, as you can see, he's got plethoric face, right? This is normal, plethoric face here. So swelling, so dyspnea, swelling of the face, neck, arm, headache, visual disturbance, pulseless jugular venous distension. Now this is superior vena cava obstruction. You need to know these signs and symptoms. So they can have swelling of the face, plethoric face, okay? They can have swelling of the neck and arm, okay? Neck and arm. Around the eyes, look at his eyes here, okay? Periorbital edema and swelling over this here. Visual disturbance, but the main thing to understand or to keynote is these first 2 bullet points. Dyspnea, swelling of the face, neck and arm. The superior vena cava obstruction. The underlying cause are many things. Most common or the most important thing for the Plab exam you need to know is a lung cancer, Pancoast tumor, which is an apical tumor that compresses on the superior vena cava. There are other things that can cause it, like aortic aneurysm, a goiter, and so on. So I'm not sure if I think Dr. Ilahi had a patient like a week ago in A&E, and he was telling me about this patient to quiz me if I know the diagnosis. There was a patient. The patient just came to A&E in Newham. Okay, he said that I want to get naproxen. Okay, because I can't get it. I ran out. Can I have some naproxen? This is all he gave for A&E. Okay, so he saw the patient, and the patient said, I have pain here and a bit of swelling. Okay, and then he took history and everything. Then the patient was seen by his registrar together. Okay, patient had swelling over this side and swelling of the face, and he just wanted to say, give me naproxen, I'm out. Okay, and we think, oh my gosh, could this patient have CVS obstruction? We done chest X-ray, lung mets. Yeah, lung cancer causing CVS obstruction. Okay, so you need to know CVS obstruction. This is cause malignancies can be caused, among the other things. These patients, okay, until you wait for definitive management, dexamethasone. But high dose oral, always is high dose oral. It's not Pred, it's Dexa. It's oral and it's high dose. And obviously, you can do stenting, chemotherapy, radiotherapy, depending on the condition, underlying cause. So, patients who are terminally ill. Now, these patients, obviously, you can't cure them. So, you need to do something to make them life more comfortable. Okay? So imagine those patients who have pleural effusion. Okay? If you have treated a patient with pleural effusion, it's difficult. Okay? So, a lot of the times in sort of you have patients who, well, when I was in gynae, I used to have patients who used to come for ascitic drainage once a week. Yeah. So obviously the fluid is building up, isn't it, from cancer? Okay. You can't cure them, right? It's mets. So that patient is sort of making comfortable as possible. So they used to come once a week to get aspiration, not to cure, to symptom. Yeah. Once it goes big, you should get short of breath and it becomes sort of unwell. So take it out, aspirate. Yeah. So same thing with this here, pleural effusion, terminally ill. Okay. You aspirate the effusion from the lungs. So at least they can breathe for the first few weeks and then do it again until they pass away. So make the life comfortable as possible. Okay. So aspiration of fluid from the lungs. Same thing will apply for ascitic drain. Okay. Patient who have esophageal cancer, stenting. Okay. Stenting can be there to symptom relief. Gastrostomy, a rig, a peg tube. Okay. So a patient who has a stroke, I worked in a stroke unit. So patient with stroke, what we do first thing we do is make them nil by mouth. Meaning, what does that mean? Nothing orally, because we're not sure if their swallowing is intact, because they could have aspiration, pneumonia. Okay, so we have a special team called the SALT team, speech and language therapy. This is what for Plab to me, and they will assess their swallowing assessment. If it's safe to swallow, okay, you can drink some water, food. If it's not safe to swallow, they say it's not safe to swallow, NG tube, nasogastric tube. okay, NG tube, yeah, Plab exam, pancreatitis, NG tube, drip, okay, bowel obstruction, NG tube, patient who has bowel obstruction, IV fluid, NG tube, drip and suck, yeah, drip and suck. Drip is the IV fluid and suck is the NG tube, bowel obstruction. Pancreatitis, NG tube. IV fluid and NG tube, drip and suck. These two things you need to know for Plab 2 exam, Plab 1 exam. NG tube, okay? Aspiration, so any patient, difficulty swallowing, had a stroke, first thing, NG tube. The problem is NG tube is not permanent, it's temporarily. So imagine a patient has a problem, has a high risk aspiration. Imagine patient A had a stroke, okay? We can't, and this patient is basically, say, 45 years old patient, and he had a stroke, and he's going to live, but his swallowing is affected, and that won't get better. Okay, so he's an NG tube, but he will live. But we want to make his life comfortable for the next whatever years he has. But he can't be NG tube, so we need a permanent solution, gastrostomy. Gastrostomy. It's a peg or rig, yeah. Or it's like a surgery they do, and they put a tube into the stomach for feeding. Okay, NG tube is temporarily, key for exam, temporarily NG tube, permanent gastrostomy. Now this is the fun side, morphine. Okay. Oh, we don't have a board. I have to get a board for this. So morphine, I'll get a board quickly because morphine is important. You need to know, please have a read of this morphine, okay? Guys, have a read. What is the difference between modified release and immediate release? Okay, morphine, you need to know, is opiate, okay? Whenever you think of morphine, you think of constipation, okay? That's the first thing, yeah? But whenever you think of morphine in acute stage, like ACS, okay, is vomiting, nausea, vomiting. Treatment is going to be metoclopramide. Patient coming with ACS, morphine, 10 mg, morphine, IV, whatever mg you want to give, plus IV metoclopramide. IV metoclopramide. Morphine, long term, imagine I give Peter morphine once a dose, only once, yeah? I don't have to think about, constipation at the moment. Main thing, the first is going to be nausea, vomiting. Okay? A patient who are placed on morphine, think of constipation. That will cause constipation. Okay?